Welcome everyone to the final member-led session of National Voices Conference on Health Inequity. So just to give a bit of context, this is the third session today on digital exclusion, and it's the third day of our conference, and there's one more day, which is next Tuesday morning. Just going to go through some tech before we get started. So here we're using Zoom webinar, which is a little bit different to the non-webinar version. So as attendees, you won't be able to unmute yourself, but you can engage in the chat. So do please get involved in the chat, say hi. The chat will still be there from the last session before as well. And if you want to direct any questions directly to the panelists for the Q&A at the end, do use the Q&A box as well there. So we're also going to be circulating a contact form. So hopefully one of my colleagues will be sharing that in the chat. So that column typists. So if you click CC at the bottom, you should be able to read captions. We welcome everyone throughout this conference to put their pronouns in their name if they feel comfortable. If you want to get involved on Twitter, the hashtag is NVHealthInequity. And if you have tech issues, please email info@nationalvoices.org.uk. So today is the human within the digital. That's the name of the session. And we're really lucky to be joined by members Future Care Capital, MacMillan and Compassion in Dying, who it's safe to say are all very, very different, offer very different perspectives. So it should be really exciting. What we're talking about today is using storytelling as a digital tool. So we're going to be talking about using storytelling as a tool for patient engagement, so for building trust within communities. We're going to be talking about how to share and use stories authentically and ethically, and what that means. We're going to be talking about using storytelling to influence policy and spark important conversations, and to improve health outcomes. So it's worth just mentioning that we had a Twitter poll go out where we asked if people had found it harder or easier to engage with their communities and their beneficiaries after this switch to digital necessitated by the pandemic. And what was really interesting is that almost the same amount of people said that it was easier as said that it was more difficult, which I think is unsurprising in a way, especially considering what we were hearing this morning in our first session. Clearly, digital tools and rapid digitization of our sector presented huge opportunities, and the VCSC sector, the voluntary and charity sector, reacted fantastically and did amazing things. But these changes are all engulfed in risk. The risk of people falling off the radar, risk of people being forgotten and excluded, and therefore health inequities worsening. So I think that Twitter poll leads really well into Compassion in Dying's talk. So I'm going to hand over to Usha and Corina from Compassion in Dying now.
Thanks very much, Svenna. I'll just share my slides. Great. So yeah, thanks so much to National Voices for having us here, and to everyone who's joining this session for listening. Myself and Corina right now, we're going to talk about our experience of working with digital tools over the last year. So firstly, by sharing the real experience of the people we support to influence changes for them in policy and practice. And secondly, by changing how we deliver our community services to adapt to the pandemic. And I think it is fair to say that, as the title of our presentation suggests, it's been a story of two halves. So Compassion in Dying, we work to ensure that what matters to each person as a unique individual is known and acted upon in their last years or months or weeks of life. And we've always tried to amplify the voices of the people we support to create meaningful change in policy and practice. But when the pandemic hit, the renewed focus on digital interaction meant that we started sharing people's experiences in a more dynamic way. We hosted a series of webinars in which people impacted by the pandemic had a platform to present their experience and really to speak kind of their truth to policymakers. Another example is we asked people to share their experiences of end-of-life care during the pandemic with us over Zoom, to submit as a video submission to the House of Lords Life Beyond COVID committee. And we were inundated by people saying they wanted to do these sorts of things. And what you can see on this slide here is a still from one of our videos of Sonia, whose husband died in Scotland of lung cancer last year, telling her story of just how they really wanted somebody to be honest about what was happening to Alan, but nobody was. So these formats allow people to tell their very personal stories over the internet in their own words, from the relative safety of their living rooms. And they told us that the low time and energy commitment of a 5-minute Zoom chat made this sort of thing possible for them for the first time. And from an organisational perspective, we also found it much more effective in influencing change to policy and practice. So, for example, these videos have resulted in joint working new projects with organisations and healthcare professionals. NHS England has also now published much needed guidance for people on do not resuscitate decisions. And importantly, these sharing stories in this way has contributed to culture change, I think. So, for example, several high-profile doctors have started publicly using the language that the people in our webinars asked them to use. So it's been, I think, abundantly clear that the people that we're trying to influence from a leadership and policy perspective are receptive to digital messaging and storytelling as a way to make change happen. But these influencing successes were set against a backdrop also of a significant increase in calls to our national information line. So at a time when death and dying was in the public consciousness like never before, we were just inundated with calls from people asking questions about what would happen to them if they got coronavirus, what would dying at home be like. Something we heard a lot was people wanted to know how to ensure their voice was not lost in an overstretched NHS. And I think there's a big but to this, and this is really significant. The changes in how we delivered our work that the pandemic brought about actually had the opposite impact on the people that we support through our community engagement work. And we found, as I know lots of others have done, that the pandemic disproportionately affected people who experience health inequalities. So the people who access our information line are predominantly white with high levels of health literacy, whereas our community engagement project works specifically with different communities known to experience health inequalities. And while demand for our information line shot up, actually demand for support to plan for the end of life in those communities overnight became almost non-existent. So I'm now going to hand over to my colleague Corinna, who's going to talk a bit more about this.
Hello, so my name's Corinna and I work alongside colleagues in Lambeth on the Lambeth Advanced Care Planning Consortium project, co-leading the work with Healthwatch Lambeth. This project is a local, place-based, community-led project with a range of local partners who you can see here on this slide. It involves local people as champions and volunteers. They raise awareness and provide one-to-one advanced care planning support directly to their peers. Together, we agreed to try and reach particular communities in Lambeth who we know experience health inequalities: Portuguese speakers, carers, people with long-term multiple health conditions, people with dementia, and people with learning disabilities. We aim to enable all local people to plan for their end-of-life care and their care needs so they get the treatment and care that's right for them. It's a project that's built on relationships, trust, building a sense of common purpose and togetherness. Building awareness for the need to plan for end-of-life care in all communities, not just the health literate middle classes, which is why it has the community engagement focus. And demand for support delivered through this project took a massive hit when the pandemic came and human contact and connection moved online. We tried to switch online, Zoom, WhatsApp, phone calls, but take up for the service plummeted. People kept on waiting to meet face-to-face again. Sure, we had, as I'm sure you did too, brave, committed volunteers with umbrellas in gardens. But when that wasn't possible, most people just wanted to wait until they could have a conversation face to face properly. For lots of people, they were coming to this topic for the first time, so having a conversation with someone they didn't know on a computer was not comfortable. In the words of someone I supported, "I'm looking forward to sitting in a room surrounded by people, to be honest. I'm not a fan of using Zoom. I find it hard relating to a machine." People told us they missed being together. The body language signals we give out when we meet in person, the shared food, the proximity, the physicality of it all. Simple get-togethers in community spaces, the kind you can see in this slide of Stockwell Partnership's Hugs group. Suddenly, no one wanted the one-to-one support to have conversations about their wishes and make advanced care plans. We found that for people with capacity issues and cognitive disability, it was virtually impossible to manage the types of conversations we needed to have over the phone or online. The extra communication needed, the visual clues, the physical reassurance were missing. A face on a screen, even a friendly one, just didn't work for many people. And also many couldn't get the necessary IT to work or even have it. We found the lack of opportunity for incidental community-based conversations particularly difficult when trying to reach new people and interest them in the idea of end-of-life planning. We tried to move community events online. In summer 2019, we held a Before I Die tent at Lambeth Country Fair. It had over 400 visitors. We ran a Before I Die wall where people peg cards of their future wishes regarding end of life. It's a really meaningful yet fun way of getting people to consider this topic for the first time. You can see a picture of it on the slide and a picture of the online version we tried in 2020, which we promoted using all existing networks, Facebook, etc. We use something called Padlet. It's a free online blank board that can be used on any smart device to invite participants to collaborate in collecting ideas and sharing information. We chose it as it's user-friendly and you don't need an account to join. We got response. The tech worked well, but only 14 responses. It was not the same as running a tent with a footfall of thousands of local people, all interested in attending a local community event, wandering past, having a chat, people having the opportunity to hear stories of other locals and meet local GPs. What was clear from the people we were working with was that while we can say that we offer the same opportunities online, for many people, these actually aren't the same opportunities. Having said this, what has been clear is that for some groups of people we work with in the community, the increased digital provision has made their life easier and actually increased people's willingness to engage with end-of-life planning. Carers tell us they struggle to find time to go to meetings or get support for themselves, and therefore the opportunity to talk in Zoom groups and get support to complete advanced care planning documents online has worked well for some of them because it has saved a person.
Thanks, Corinna. So I think there's a really big warning here that we must not homogenise people at risk of health inequalities into one group and seek to find one solution for them. I think every community will have different needs and different motivators, and there's just no silver bullet when it comes to combating digital exclusion. A one-size-fits-all approach just doesn't work. And I think for compassion in dark, learning and giving people from lots of different communities a voice at actually quite a high level. And videos work really well to ensure that authentic voice. But when it comes to engaging people and communities, we just haven't been able to create anything as powerful as sitting down with someone you trust face to face and talking. Power of communication has been vital for us historically in gaining trust and opening up conversations that ultimately lead to better health outcomes. And many different communities have told us recently that for them, this human connection just isn't as easily online. So what I really hope is that that's been an honest reflection from our perspective of both how digital has and hasn't worked for us. I find the result of the Twitter poll that Savannah mentioned earlier on absolutely fascinating. So I'm really interested
with ideas of digital solutions and, as you say, homogenized communities. But one thing that stood out for me as well was, clearly storytelling does provide a lot of opportunity. And we were talking about power this morning and the ability to share power. And I think there is a real opportunity with using digital tools for that. And it's reminding me a bit of our COVID Voices, which was a website that National Voices launched in the first wave of the pandemic, which allowed people to share in their own words, in their own time, from the safety of their own homes, their own stories. So I think, that was really, really important to hear. Thank you. I'm going to introduce Eleanor from MacMillan now to share some of their work and talk about the evidence of storytelling as well.
Thanks, Savannah, for that introduction. I'm really delighted to be here today to share with you what human in the digital means for us at MacMillan, and to tell you a little bit more about our digital story that we've been doing for the past year in partnership with the Scottish Book Trust. So MacMillan really got involved in digital storytelling because of the evidence, and if you could put the next slide up, please, that'd be great. The evidence around, the effectiveness of this methodology in amplifying voice and advocating for improvements in health and social care. We chose to work with Trust because they have an existing track record in engaging some of the most disadvantaged communities in Scotland through a project which was focusing on the increase of digital literacy on behalf of the Scottish Government. But also we worked with them because, pre-pandemic, we had planned to do our work face-to-face with our partners in the MacMillan Library Information Services. So that would be working really face-to-face, right in community with the community members there. But like everybody else, we had to very quickly change track, and we were delighted to get everything back online using a video editing, a cloud-based video editing piece of software called WeVideo, which, like quite a lot of other parts of the methodology that we use, is based on the Story Centre in the States. So we were delighted that we could just repurpose the whole project, which meant that we weren't working community, obviously, but it has given us a lot of advantages in terms of the people that we actually can reach. So that's been a real advantage. Of how impactful digital storytelling has been at a policy level, and particularly when presenting challenging subject matter to policymakers. And that was through a project that I became aware of to raise awareness of female genital mutilation, where the stories and the storytellers were presented to committee at the Scottish Parliament, and that had a significant impact on the work there. So with all of that, I was really convinced, that this methodology was for us, and our project's been running for just under a year, and we're really delighted that we've just got funding to roll it out for another year across MacMillan UK on a digital storytelling champions model. But essentially for me, I believe that if MacMillan and the people that we work with are really truly to put people affected by cancer at the heart of everything that we do, then those authentic stories about what matters to people affected by cancer are absolutely vital if we really have to have any effect on reforming health and social care and challenging health inequalities. So in short, people's stories put the human back into healthcare. And these stories really remind us that people are so much more than their diagnosis. And I think there's nothing really better to demonstrate that than to share a story with you. But as well as the storytelling, what's absolutely core is the listening and the reflection. And that's two key parts of what we do, both in generating the stories, but also in sharing the stories. So we're going to take a couple of minutes just to share a story with you. But before we do that, Savannah's going to introduce a wee Mentimeter so that you can take that time to reflect back as well. So I'll hand you back to Savannah for just now before we share the story.
Thanks, Helena. So in the chat now, my colleague Laura will be posting a link to Mentimeter. So if you can just click on this link what it will do is it will take you to a screen and you can type in thoughts or feelings that emerge while you're watching this video. So you can do that while the video is going on. I'm just going to share the video now.
Thank you. And this story is from a lady called Moira, who was one of our first storytellers. And we always ask the storytellers to also tell us, the content and share, on the thumbnail. And Moira calls this story, "It's Not Selfish to Look After Yourself." Thanks, Savannah.
I was driving down a dual carriageway when I hit black ice. Then I hit the central reservation, then a lorry, then the central reservation, then the lorry, and so on, just like a pinball. And what was going through my mind while this was going on? Well, I was thinking, I wonder how this is going to end. I wasn't panicked, I was genuinely intrigued, and I didn't feel particularly scared. I presume a combination of shock and adrenaline had a lot to do with this, but the wonder bit didn't. Wonder's a great word. It allows you the freedom to explore different outcomes without feeling a huge investment in one over another. I discovered its power when I started to work on my insides. For years, I wasn't content with the way that I felt about myself, so I read lots of books and I also decided to go to counselling. At first, I thought this was a bit self-indulgent, but actually, I learned that there's nothing selfish about looking after yourself. And at the end of my course, for the first time in my life, I felt comfortable with who I am. A few months after my crash, I was diagnosed with breast cancer. Although I was surprised, my response was similar to when I was skidding on black ice. I was genuinely intrigued and wondered how it would pan out. At my first consultation, I was told I had a very small tumour, 16 millimetres, no bigger than my thumbnail. At my second, I was told the cancer was lobular, which is flat and it's trickier to see, so I would have to have further tests. While the tests were getting underway, a friend and I created a big mind map. It covered everything from chances of survival to prosthetic breasts. The nurse I took this to was initially a bit taken aback and felt that she might not be able to answer all of my questions. But once I explained that the map was just a way to get everything that was in my head onto paper, she was fantastic and she told me loads of stuff and even found a prosthetic for me to look at. When I visited my GP with a lot of questions, his first response was to tell me that I couldn't control the situation. Again, an explanation was required to let him know that that actually wasn't my intention. I needed information to be able to make informed choices. By the end of my appointment, he totally got it and told me to keep asking questions of anyone and everyone. He was just lovely. The third time I had to explain myself was at home. My all guns blazing approach was seen as not taking other people into consideration. I think subconsciously I knew that this was a pivotal moment and my response would determine how I would feel as I went forward. Normally, I would have been very quick to apologise, and before all my working on the inside, I would have felt awful for being selfish. But instead, I pointed out that I'd spent my whole life being considerate to others, and now my priority was me. It was me that was ill. How I chose to deal with my situation was also up to me. And basically, everyone else could take a run and jump. And I used far more colourful language than that, but I'm sure you'll get the gist. My fiery, somewhat out of character outburst met with greater understanding than I expected and an acknowledgement that I was absolutely right and should bash on in whatever way worked best for me. The outcome with the nurse, the doctor, and at home would have been very different if I had still been lacking in self-worth. Having learned to value myself helped me to stand my ground and get the things I needed for my journey. Working on the inside also helped me through all my treatment. I had a mastectomy. The tumour turned out not to be 16 millimetres but 10 centimetres, so I had to have chemotherapy followed by radiotherapy. It certainly wasn't always plain sailing, and I wasn't especially brave. My courage centred around believing that I counted and acting as if I did. And throughout it all, there were lots of wonderful moments when I felt really content and cherished. Now, when I look back on my experience, I see it as a most incredible adventure that even if I had the chance, I wouldn't change.
Thanks. Savannah, and do you have the B results of the reflection you can share?
Laura, if you're okay to share the screen for the Mentimeter. So thank you to everyone who contributed to the Mentimeter. So here we have some words, some thoughts and feelings that sprung to mind as people watched that story. So powerful, courageous, inspiring. I can see inspirational is there a couple of times. I can see the word human there. And I think, yeah, that is really important. Eleanor said something just before about I wrote it down. People are so much more than their diagnosis. And I think that everyone will do well to maybe reflect on that even more than we do. And I think videos like that really, really help. Thought-provoking, wanting to give her a hug. So clearly it's really, really connecting to people and really sparking emotional responses, empathy, sympathy, accessible, which is really, really important. And I think one thing we can definitely see about digital storytelling is so many of the practical barriers for people sharing their story again and again, if it was physically, just disintegrate. So that's really great. Staying in control, so the person staying at the center of their own story. Dignified, incredible attitude. So it does seem to be having a real effect on people's feelings as well as their thought process. So I think that's, yeah, thank you so much to everyone for contributing to that word cloud. I'm going to hand back to Eleanor now, but we will be sharing it on Twitter and via email. So thank you.
Thanks, Savannah. Thanks everybody for sharing those reflections. And all of those things are really, really important to us as we create these stories and help people find their stories. But just to come back a little bit to the main project, the project had two kind of main overarching objectives, which, although we're really quite early in our project, we feel we're really making good inroads to achieving those. So first of all, the stories were fully intended to have created as an advocacy resource to encourage engagement with our cancer communities. And we're delighted that we really now have a network of highly engaged storytellers, and that's been built through genuine trusted relationships, and they are really, really keen to stay with us and continue to be involved in MacMillan and help and support other people affected by cancer. So that's, we're delighted with that. Next, we want to really build on the stories and build on this network, and we're creating a series of online conversations, which we're calling Conversations That Matter, about what matters, where the stories will be absolutely core in the keynotes. So the storyteller will really set the theme and the content for the conversation, and we're encouraging both peer-to-peer and peer-to-professional conversations, because you'll see me now saying a lot of the, what matters to you. All of our engagement work in Scotland and MacMillan, all, of the stories that underpin this, all come back to what matters to you, and that kind of international movement, which is really driving the whole personalisation agenda. And I don't think we can really, even talk about the personalisation agenda or personalised care without getting to the heart of what matters to people affected by cancer. So our second aim is really to deepen our own understanding of what matters, through those authentic experiences, and to really move away from that kind of almost stereotyped story of cancer. We often hear people talking about their cancer journey, and it's almost a kind of rote reflection on what they've experienced, and it's a very often transactional story. So we really wanted to get underneath all of that and to not discount those experiences in any way, but to get underneath it to really understand what really matters to people at those points. And we've done that by ensuring that we can work through a process that keeps people in control. It gives them choice and flexibility, but it's all the time, it's wrapped around, safety and support. So we've got all the safeguarding and ethics, again, directed by the Story Centre, and a lot of this work is coming from that international movement. And through this deepened understanding, we hope that we'll be able to really redress, as Savannah says, that balance of power between healthcare professionals and people affected by cancer. And offer decision makers a different kind of opportunity to understand the needs of people from a diverse perspective. So just to conclude, I wanted to share where the stories have been able to have impact so far, and some of the plans that we have moving forwards. Just last week, one of the storytellers shared a story at the MacMillan National Staff Conference, and that was a 2-day conference. And the story and Genevieve just really set the tone for the whole 2 days, and that went out across thousands of people who work for MacMillan and our professionals. Another of the storytellers was invited to speak to the research team at the Beatson Cancer Centre here in Glasgow. And this was extremely impactful. They said that this is the most well-attended meeting they'd had of that kind. But I think more than that, more importantly for the storyteller herself, she's just really lacked so much confidence before she did that. And in her own words, she says, I thought I had nothing. Really anyone would be much interested in listening to, and now she realises that the value of what she's done in creating this amazing digital story, people do want to listen. It's also opened up new possibilities for advocacy, and one of our storytellers has used the digital skills that she's learned in the project to create another story called The Border Between Us. And this has been part of a Northern Ireland and Southern Irish border project, and just using the skills, and we're just really excited to see how the storytellers are going to use these skills, use what they've learned from us and those experiences and the confidence that they've gained, to impact other aspects of their lives, but also other aspects of their own community work. So loads of different impacts we can see and the potential, for us moving forward. But I think most importantly is our evaluation project evaluation report is recently reported is that they've had a significant impact on the people and the storytellers themselves. The increased confidence, a belief in themselves, a belief in the value of their own experience, and it's almost been like a therapeutic value. One of the storytellers says it's almost been like putting things to rest. It's been like unpacking a suitcase and repacking it in a way that's all organised and sectioned in a way that makes sense to me. So that reflection for them, that the care that we've taken over to let them process a really difficult part of their life. It has surfaced a lot of difficult things, but it is, as one storyteller says, it's telling my story has allowed me to offload a burden that I didn't even know that I was carrying. So they're just a few of kind of many other outcomes that we're delighted to share. Moving forward, we're next week, we're really starting to focus the project in challenging health inequalities as we focus our work on communities whose voice is often missing within MacMillan, but certainly missing within health and social care. So next week we're starting a workshop with the deaf cancer community with the help of Self Help UK. We're just about to upload stories onto the website from the work we've done with the BME communities through our work with our partners and colleagues in MacMillan in London. And we're planning internally to promote the stories through a regular story of the month through our intranets, which will go out to all MacMillan professionals and all MacMillan staff. And we're encouraging them to just take 3 or 4 minutes to centre their practice on the lived experience of someone affected by cancer and remind us all of why we're here and who we serve. And that's
Thank
me.
you so much.
Savannah.
I'm definitely, as I know from the chat, not alone in just thinking that everything you said is so valuable to hear and so thought-provoking. What you were saying about how one of the storytellers said that telling the story is like unpacking a suitcase and packing it in a neat way just made me think of what we've talked about, and what is a theme that's crossing over a lot is putting the storyteller at the centre of their own story, and that sort of control and able to rewrite your own narrative. So thank you so much. And I think just bringing it back to sort of health inequity and the conference as a whole, I think so often inequities are embedded or inequalities through ignorant, not listening to people, or ignoring them. Often talk about hard to reach communities, but easily ignored communities, or making assumptions. And I really think that storytelling and stories are such a powerful tool to combat this. So therefore, powerful tool to help in the fight against health inequity. So thank you so much. I'm just going to introduce Josephine now from Future Care Capital to give us a very, very different perspective. So they've been using fictitious stories to spark conversations about near future health and care issues. So Josephine.
Thank you. I'm going to share my screen. Can you see that? Yeah, good.
Yep.
So yeah, thank you so much for inviting us to come along today. It's been really, really interesting to hear the stories already presented. And like Savannah said, I'm going to take a slightly different perspective on storytelling in health and care. So I am the Senior Research Officer at Future Care Capital. Future Care Capital is a charity and think tank focused on health and social care. And we have a particular interest in issues relating to data, technology, and innovation. So that kind of space. And I just want to also credit Vincent Chong, who's produced all the wonderful artwork that is in this presentation, and is also produced especially for this fiction series that I'm going to tell you about. So why use fictional stories? Well, historically, storytelling has been used forever to put highlight on contemporary issues, for people to better understand things that are happening around them, and to generally pass on stories from one generation to the next. But there's also research to show that fictional text is processed slightly differently from facts and factual information. So people who read fiction on a regular basis, for example, have been found to find it more easier to empathize with other people and find it easier to take other people's viewpoints when considering an issue. So this is a quite nice point of view for understanding issues in health and social care, and particularly thinking about near future issues and things that have not for technology, for example, that isn't quite here yet, but maybe it's just on the cusp based on what we're looking at we have already. So we developed this kind of series as a way of engaging both policymakers and practitioners and other stakeholders in this space, and encourage them to think about these kind of issues in a new and different way, but also as a way of engaging people who might not be very likely to read policy reports, for example, or research or other factual information, and might find it easier to engage with a fictional take on particular issues. So when we first started thinking about this project, it was over a year ago, right at the beginning of last year, or maybe even towards the end of the year prior to that. And we started thinking about what type of fiction would best suit our vision and our purposes. And sci-fi seemed like a really natural fit based on the data and technology focus that we have. And of course, we had no idea at that point that the pandemic would mean that we would all pretty much be living in a sci-fi scenario in a very, very near future, but that's just a pure coincidence. So we commissioned a series of professional sci-fi authors to write the stories for us, and the project is led and edited and coordinated by Keith Brook, who is himself one of the writers for our project. And we have a story produced once a month. We started in July last year, and it will be running until June this year. And each story addresses a particular issue that is based on something that is perhaps going on at the moment, but taking those to the extreme. So what you can do with fiction, of course, is you can look at what's happening now and then imagining that in an extreme way and looking at what that would look like in the possible future. Each story is also accompanied by a blog post, which is looking at the real world implications of the technology or the concerns for each story, so that we can kind of ground it in what is happening at the moment, both in in innovation, but also in policy terms. And the aim of the project, of course, is to stimulate discussion and debate and to engage the audience. So as an example of one of the stories that we have run in our project is a story called All I Ask For, which is written by Anne Charnock. And this story has actually been nominated for the British Science Fiction Association Award for Best Short Story, which will be decided in April this year, so just in a couple of weeks' time. And this particular story is looking at fertility technology. Specifically, it's looking at a future scenario where use of artificial wombs is a possibility. So the protagonist of the story herself is a woman who has conceived naturally, but because of her age at the time of conception, she is persuaded by doctors to use a baby bag. So she had a cesarean at 22 weeks, baby removed and put into a baby bag because it was deemed safer since she is an older mother. And the story kind of follows her feelings and experience of having her baby grow and gestate remotely from her, and how that works for her and for her partner in their sort of feelings in developing this baby and having that happening separately from herself. This kind of story is talking about technology that does not yet happen, but it's not perhaps so far off. Technology like IVF would have been considered sci-fi not that long ago and is now standardly used. So it's an example of taking something that could be a possibility for the future and looking at what implications that have for the people involved. Another story from this is Life's Lottery, which is written by Keith Brook. And in this story, the woman we are following is on a waiting list for having an operation. In this scenario, which utilizes wearable technology, each individual's likelihood of receiving the treatment and care that they need, in her case, this operation, is determined on the behavior that they engage in, and then algorithms are used to bump people up or down the list of priorities for the treatment that they need. And through the story, she is slowly realizing that she is never going to receive the treatment that she needs because she is not high enough on the priority list. So the story looks at how she is using hacks to cheat the system, to present herself in a new way, fake a new identity in order to be able to receive the treatment that she needs. And though we are not there yet, we know that already algorithms are used in ways that are not always ideal. The whole A-level fiasco from last summer is an example of that. And looking to the not too distant future, we can see the sort of suggestions of the need for vaccine passports, for example, for not just traveling, but for engaging in all kinds of activities, has the potential for if not faked identities, so at least certainly faked medical records, if that is becoming an issue. Other stories in our series have dealt with things like end-of-life care and virtual reality and end-of-life care, misuse of private data for profit in health, and future care, social care scenarios. And like I said, we also have a blog associating each of the stories, that exploring technology behind the stories, looking at where that is in the here and now and what we could expect for the future, what is possible, what might be possible soon, and also addressing some of the ethics in the here and now of what the implication of technology or treatments and so on is for care. And this is some of the feedback that we have had from what has been happening so far, and it's all been very positive, I would say, and I'm particularly happy about this one down on the side, which is from a practitioner who's saying that the shared virtual reality experience of the special moments of life is already possible, and I have done it with a few patients and their families, and this has inspired me to do more. And that's the kind of feedback that is really showing the sort of the impact that this type of project has had. So like I said, the stories are published monthly on the third Tuesday of every month, which means that the most recent story went up this morning, and they're running until June 2021, so June this year. And we invite you all to come and read the stories and to join the conversation at Future Care Capital on the project page for the fictions series. And we're always happy to hear from people and let them know what you think about this project and how it might impact practice. So thank you.
Fantastic. Thank you so much. That's absolutely fascinating. And I personally had never heard of anything like what Future Care Capital are doing. I actually was telling some of my friends about it the other day, and we were reading the fictions, and it just really is fascinating. So thank you for sharing, and really different perspective. We don't have that long now, but we'll move on to the Q&A. So one question that I'd like to ask everyone is, so there's been actually a couple of questions put in the chat about reception of the stories and also about advocacy. So on the one hand, how can we, what can we do about reception of the stories? One person mentioned that in the word cloud, there was words like shock and discomfort put in. And then also on advocacy, are there any tips people have in terms of getting these stories not only in front of healthcare professionals and policymakers, but on actually influencing that to move into action? So if we can start with Usha or Corinna, is that okay?
Yeah, sure. Yes, really interesting point, that, like picking up on the wording in the video that Eleanor shared about shock and discomfort. I think we've certainly found that from a kind of policy perspective and an individual like health and social care professional perspective, using videos has meant that people can see it in that person's own words and see them talk about it. So, and what that means is that they can't invalidate those feelings at all. So it's really different to kind of when you put it in a policy report and people kind of pick it apart a little bit and think like, yeah, but you know, I don't do that, or I don't do that. But when you allow someone to tell the story in their own words, you can't argue against that, because it's what real people are saying, and it's real people's experiences. So I've sort of found that actually in terms of overcoming like shock and discomfort, videos have been much more powerful than the written format. And what was the other question? Just in terms of like a vehicle for creating change, and like how to ensure that it's done.
Influencing tips to ensure results.
It's a really good question. I think definitely for us, the influencing successes have come from like broad like policy area opportunities. So for example, like parliamentary committees and kind of getting the videos to kind of as senior people as possible who had time to watch it, rather than having to kind of target individual GPs or individual clinicians. So I would say like looking for any kind of policy openings in terms of consultations and that kind of thing to shoehorn it into, or any kind of open areas of policy work that are already being looked at, it has been most useful.
Great, thank you. And then I don't know if Corinna, if you had anything to add to that, or if we move Eleanor?
Yeah, just picking up on the shock, and some of these stories will be really, really difficult, but that's why we've done it, because these are really, really tough things to talk about. It's really emotive, but we, you know, like Usha said, we want to give people that authentic voice, because they find it difficult to say, and they won't say it, and that's why they get into this transactional account of their story, because that's easy to tell. And you know, the deeper, you know, more sensitive stuff, you know, they don't want to be sitting crying and, you know, every time somebody asks them about something. But this gives them a chance to get all of that out in a way, and then they can show that story and be beside that story, and then just answer questions. But they don't have to deal with the emotional, you know, processing of that every time they have to talk about their story. That can be there, and people can engage with that. So yeah, it's really difficult subject matter, and I think that it absolutely particularly lends itself to having these really difficult conversations. Because as to use the example of the female genital mutilation, I can't imagine standing up in front of a bunch of men in the Scottish Parliament and talking about that. You know, you just couldn't, you know, but you could answer questions on it. So yeah, for me, that absolutely sits where there is discomfort. So I don't disown any of that, and I won't shy away from it. Especially around stigma, that people experience, all of that really difficult. I'm absolutely on board. In terms of how we move forward, most of our approach will be around the conversations that the stories spark a conversation, that we can bring, it's not just something to watch and go, oh, that was a nice story, and then I'm away doing my business as usual, but we want to really place them in a place where we can reflect and bring those conversations together. So that's the approach, embedding it within the L&D arm of MacMillan, so that we can get out to professionals, cancer experienced nurses, all the stuff that we put out there. How do we bed it in there? So that's the kind of approach we're taking in any opportunities at conferences or in front of policymakers. I'm not saying it will be high level, but we'll just chip away at where we can to get them in front of people.
Just on what you were both saying about the feelings it sort of generates. Someone just put, I saw in the chat somewhere, of course, stories generate such reactions, and that's why the whole of film and novels and everything like that is so powerful, and it's true. It builds empathy in a way that a dry report maybe doesn't. So Josephine, just moving on from what Eleanor was saying about influencing, I was wondering, if you could talk on that as well, and on any influencing tips for using the stories and trying to get the best reception possible.
I think in terms of influencing, I think that the fictional stories, in a way you can use them and you can be even more shocking than you are in real life, because you have that kind of cushion of it not being real and it being fiction. But on the other hand, you don't get the same emotional impact as when you have a person telling their own personal story. What I think that fictional stories can be really good at is taking controversial issues and issues that have a lot of stigma attached to them and use them as a starting point for maybe opening a conversation about a particular issue, and then enabling people to have the words and the vocabulary to talk about a particularly difficult issue, and maybe help in that way by opening the conversation.
Great, and I've just seen in the chat you should just put something about being, how I read it was essentially being really explicit about the change that we want to make, and I think that's something we can say about this conference as a whole, and if we can move forward as a sector. I mean, this is such a great example of collaboration, but I think being really explicit about the change we want to make is hopefully going to make us all more influential as a sector moving forward. So another question is about building trust. Someone mentioned, obviously, many charities are mostly white, middle class. A lot of people may not see themselves reflected in the people asking for these stories. So I wanted to ask if anyone has tips on building trust, getting these stories from people. But that's exactly the point I want to make, is not going into it with that mindset of being extractive or data mining. So what are people's sort of top tips when it comes to empathetic storytelling? Yusha?
I've got a quick one, which is what we find most powerful is like peer support. So whatever community it is that you want to work with, kind of finding a trusted person or a trusted partner in that community to act as champions, probably the wrong word, but really you don't want to be going up to somebody who doesn't feel like they have anything in common with you at all, and asking things of them. So trust is best built when it's from somebody that you trust and you have an affinity with, and that you share experiences with.
Fantastic, thank you. Corona, do you have anything to add on that?
I think just to say, sometimes it takes a long time to build that trust, and that's fine, because you have to earn it. And so working with communities and different organizations, it can take 2 or 3 years before you've got a really good, strong trust relationship. And that's when you start working properly together, because, some of the sort of ways that people have worked with people in the past do mean that there is mistrust in those communities, quite rightly.
Thank you. And Josephine, if we can go to you next. So you've obviously been using fictions. So actually, I did have a question on this, which is leading up to using fictions, is there a lot of engagement with people as individuals to inspire those fictions, and how do you garner trust when doing that?
That's a really interesting question. We haven't done that as such on an organizational level. So we've left it up to the, well, we did have some sort of consultations right at the beginning about particular topics and things like that of what would be suitable. So we had a little bit of that, but to a large extent, the authors have been choosing the topics and coming up with that. And we actually have, because as I mentioned, Anne has been nominated for this for the Science Fiction Award, and so we have an interview with her on our website as well, where she's talking about how she came up with the story and how that develops and her thinking process behind that. And we're going to do that with more of the authors as well to kind of to grab that. But we haven't had direct interaction with people to try and tell real stories through fiction, if that makes sense.
Thank you. So just last word, Eleanor, if that's okay. So yeah, what are your top tips for ethical, authentic storytelling and building trust with those storytellers?
Yeah, we use the ethics document, so everybody before they get involved gets the ethics document, just really highlighting that the storyteller is always in control. At no point will we ever force them to write what they don't want to write or share. And I think that whole consent process and the GDPR all around it, it really safeguards the storyteller at every single juncture. They can drop out whenever they like. They can do the whole process and come away with their story and not have to share it. We never ever that they are absolutely, and it's very clear, that we, procedurally, they're in control of their story, and we never force that upon them. We use a kind of champions model as well to where we've got relationships with people to get their stories created first, and then they can share them with their communities and hopefully bring more people that would build the trust. But I think what's come out from the work is the facilitators themselves share of themselves. So they share stories of themselves, and that builds trust with the people who are in the workshops. And that's been a really important. The facilitators have just, I can't, congratulate them enough. They've just been absolutely amazing. And, that's where all those, somebody asked about the, some of the unexpected outcomes, that therapeutic element of it was completely unexpected. We did not expect people to find themselves, to find their story, to uncover and find actually recovery through this process. So that was, we didn't intend to set out that way. So the sharing of self, I think, really, really important, and that allows other people to come to build their trust and share of their self.
Thank you so much, and thank you to all of you. Genuinely such an interesting session, I thought, anyway. So just to sort of close, obviously, just going back to the poll, which we mentioned really briefly at the beginning, 47% of people said that it was more difficult to engage with their communities digitally, and 40% said it was easier. So clearly, as Usha said, we cannot homogenize communities. So I think that has just been something throughout today that has just been repeated time and time again. We cannot make assumptions when it comes to digital exclusion. And that's really what personalised care means. That's what it's all about. And that's what National Voices is all about, personalised care. And health inequity really just does come back to personalised care. So we're going to be sharing, I think some of my colleagues have shared a contact form. So do sort of share contacts, collaborate even more. Use the hashtag #NVHealthInequity, and also we hope to see everyone next Tuesday. We've got an hour and a half session in the morning, and it is our closing session for National Voices Conference. How can we dismantle health inequity together? So thank you so much for today's speakers. Thank you so much for everyone who has put all the work in behind the scenes to this conference, and hopefully we'll see you next Tuesday.